To me to introduce my co-chair, Dr. Leschner from Emory University. I'm sure you all know him. He's going to speak to us on emergent TEVAR for acute aortic syndromes involving the descending thoracic aorta. Bradley.
Thank you, Christian. And it's a privilege to present our experience with emergent TEVAR for these interesting pathologies we face. Here are my disclosures. Everyone kind of has an understanding that open emergent surgery for anything on the descending thoracic aorta is fraught with a lot of morbidity and mortality. These are the main sort of pathologies that we would treat, and really the first two, aneurysms or pseudoaneurysms that are ruptured, or complicated type Bs, those are the ones we see the most. The others are sort of case reports in the literature that do poorly. And TEVAR has really replaced open surgery for a lot of this. So our objective here was to just review our experience. So we looked over the last 3 years, we'd done 133 TEVARs, and a fair amount of them, almost, well, 40% were for emergent pathology transferred in. So about 60% of them were done for complicated type Bs, 20% for symptomatic PAUs with associated IMH. We had 7 true ruptured descendings, 3 aortobronchial fistulas, and 1 was a rapidly expanding pseudoaneurysm, but had not ruptured yet. These are young patients, 60 years old. They usually got 1 or 2 stent grafts to cover the pathology and get a successful procedural treatment. Our landing zones, we had a single zone 0, which was actually a transapical access. Most of them were zone 3, and 8 of them were zone 2. 1 required a carotid subclavian bypass. We were able to accomplish the majority of these with transfemoral access. 2 required a retroperitoneal cut down, and 1 we did have, besides a transapical, was a direct mini laparotomy and direct abdominal aortic stick. So here are our results. We had 4 mortalities. All were due to aortic rupture. 1 was an intra-op failure. We were treating aortic bronchial fistula, and we ballooned the distal landing zone, which is actually far away from the pathology, and must have ruptured a calcified plaque. It's the only time this has ever happened to me. The others were coverage of ruptured descendings, and in the first post-op week, they had rupture of their abdominal segments of their aortas. We had 1 stroke, no new post-op paraplegia, but we did have 3 transient parapresis. These were complicated type Bs that we did extended coverage down to the diaphragm or just a little bit longer. These were all treated immediately before we left the OR with spinal drains, and they recovered. 1 renal failure requiring dialysis, and 3 reinterventions. 5 were reinterventions. 4 of them required open surgery, and 1 endovascular fenestration. So to sum up this short series, this is really, in my opinion, the treatment of choice, TEVAR, as opposed to open surgery for emergent pathology of the descending that needs to be treated quickly. You have to keep in mind that you will reintervene on these patients, particularly in the type Bs, and that it emphasizes that lifelong surveillance of these aortic problems is warranted, as these patients will come back and back and back. Thank you.
Thank you, Bradley. So obviously fistula is an issue, and do you think it's because sizing is different in emergency cases, or is it the weak tissue when you have a ruptured situation, or do you think it's just the same incidence?
For the ruptures?
Yeah.
No, I don't think it's sizing. Again, 2 of these were sort of abdominal ruptures. So I'm not really sure, to be honest. I don't think it's I think that if you're landing in healthy aorta, it should be a seal.
All right, and there was 0 paraplegia and 3 paraparesis, and you treated with TSF drainage. This is something that we can emphasize maybe later when we come to that issue on spinal cord injuries. Any questions or comments from the floor? One from Japan.
Thank you for the nice report. It's at the same question. What specific subgroup of patient do you do a cerebrospinal fluid drainage? It's, I think, very important. This is it's a major comorbidity, and I think you may not avoid it in a long landing plan.
Yeah, I agree, and it's something we think about a lot.
Do you do most of cases in this kind of cases, cerebrospinal drainage?
No, we don't. So in the emergent situation, we go right to the operating room and take care of the pathology. If we can, we extubate them on the table and treat their neuro exam before we leave the OR. Our cardiac anesthesiologists are able to put spinal drains in for us. So that's how we handle this, along with augmenting the blood pressure. As an aside, even in ruptures, assuming our completion aortogram has a seal, as soon as we deploy the stent, we increase our systolic blood pressure to greater than 150 and go on pressors if necessary to get there.
Do you have any specific monitoring, like INVOS or type of, things?
We do not use, for open surgery we do, but for endovascular we do not. We've chosen not to use any evoked potential monitoring.
Okay, thank you.
Yeah, thank you again. Maybe important to emphasize blood pressure management after the case. So that was new and important to me that you even, in these cases, increase blood pressure dramatically. Right.
Okay.